Hi, my name is Kavitha Selvin. I'm an assistant professor of medicine at Northwestern University, and I'm excited to talk to you about our project, Streamlining Interstitial Lung Disease Diagnosis in Primary Care Clinic. We'll be presenting the final results of a quality improvement demonstration project today. So a little bit of background on the topic. Patients with interstitial lung disease often present to primary care clinic with respiratory symptoms months to years before a diagnosis is made. That time lost to diagnostic delays can be multifactorial, related to patient, provider, and systems factors, but that time lost leads to irreversible loss of lung function. Targeted educational interventions in the primary care setting aimed at streamlining diagnosis of ILD have not previously been studied. So the purpose of our project was to perform a quality improvement demonstration project utilizing the CHEST toolkit of ILD resources. And we wanted to implement this toolkit in the primary care setting to see if it would help streamline the diagnosis of interstitial lung disease at our institution. This study took place at the University of Chicago Medicine in primary care clinic between November of 2023 and May of 2025. We utilized a Plan, Do, Study, Act, or PDSA approach for this project. In the plan phase, which took place between November 2023 and January of 2024, we created an ILD order set in the electronic health record, and we collected baseline survey data from primary care physicians at our institution on their practices in evaluating suspected ILD and familiarity with the institutional ILD providers. In the Do phase of our project, which took place between February of 2024 and June of 2024, we provided primary care physicians with access to the CHEST Foundation's ILD toolkit of educational resources on ILD diagnosis. I'll direct your attention to Figure A here, or Figure 1 here. In Panel A, we have the ILD checklist and resource guide that was posted in all of the primary care physician workrooms that includes algorithms on how to evaluate suspected interstitial lung disease. And it also has information on different subtypes of interstitial lung disease. In Panel B of the figure, we had a patient questionnaire that included multiple risk factors used in the diagnosis or evaluation of interstitial lung disease. This patient questionnaire was provided to patients that were presenting to primary care clinic while they were in the waiting room. Responses of the patient questionnaire were entered into the electronic health record in real time to allow primary care physicians to review responses ad lib during that patient's primary care visit. In the study phase of our project, which was conducted between July of 2024 and December of 2024, we collected follow-up survey data from primary care physicians on their evaluation of suspected interstitial lung disease. I'll direct your attention to Table 1 here that shows our baseline and follow-up survey responses. And some notable findings included that following our intervention, there was a trend toward reduced number of visits with the primary care physician before placing a referral to a subspecialist ILD provider, and a trend of increased familiarity with institutional ILD providers. We also find that there was a statistically significant increase in the ease of communication between primary care providers and interstitial lung disease providers at our institution. In the study phase, in addition to looking at survey data, we analyzed patient questionnaire responses and primary care ordering practices prior to and during the study intervention. I'll direct your attention to Figure 2 here that shows the number of ILD risk factors per patient that was assessed by the patient questionnaire handed out during the primary care visits. As you can see from the figure, over 50% of patients had 2 or more risk factors for ILD that were presenting to their primary care visit. So quite a significant number of patients, though may or may not have been coming in for respiratory symptoms, did have risk factors in their history that should increase your suspicion for interstitial lung disease. In Figure 3, you can also see trends of diagnostic orders that are used in the evaluation of suspected ILD prior to and after our intervention period. Q1 of 2024 is when the intervention period began, and you can see that there was an initial spike or increase in the number of pulmonary function tests, pulmonary referrals, and chest CTs that were ordered following our intervention period, but I will note that that trend did not persist past the first quarter. And finally, I'll direct your attention to figure 4 here. We found that the odds of diagnostic orders for interstitial lung disease being placed significantly increased based on the number of risk factors for ILD that patient had. And so you can see that patients with 2 risk factors for interstitial lung disease had an odds ratio of 1.63 in terms of likelihood or odds of having diagnostic orders placed. And that ratio increases all the way up to 10.4 for patients that had 7 or more risk factors being placed. Finally, we determined final diagnoses for patients that had a pulmonary referral placed during the study intervention period. And I'll direct your attention to figure 5 here. We found that of the 67 patients that were referred to pulmonary during our study intervention, 4 were referred for a suspected diagnosis of ILD, and of those, 2 were ultimately diagnosed with ILD. 1 additional patient was diagnosed with sarcoidosis as well. In the final ACT phase of our project, we expanded toolkit resources to additional health systems, including a new health system outside of the University of Chicago Medicine. So in conclusion, what we found in this project was that primary care physicians often do not consider ILD in the differential diagnosis of their respiratory symptoms, but a targeted intervention could help change that. We found that patients with multiple risk factors for ILD were more likely to have diagnostic orders that can be used to make a diagnosis of ILD placed. And we found that implementation of the Chest Foundation's ILD toolkit in the primary care setting helped improve communication between primary care physicians and pulmonologists at our institution. There was also a trend toward less time to referral. Overall, we feel that a targeted intervention in ILD diagnosis that occurs in the primary care setting could help streamline and reduce the time to ILD diagnosis. Thank you so much.